Hi, everyone, and thank you for joining us for today's webinar, Brain and Exercise, Integrating Neurology and Medical Fitness. I'm Marianne Murphy, the Director of Marketing here at the Medical Fitness Association. Now, today's webinar is sponsored by MFA industry partner Reaxing, the world's first company to create equipment and training solutions for neuroreactive training. Now, I'd like to take a moment to introduce today's presenter. Brian Blatt is a personal trainer and board-certified health coach with a specialty focused in brain health with over a decade of experience in the health and fitness industry. He currently works alongside clinicians and researchers to implement cognitively enhanced and comprehensive exercise and lifestyle interventions at the Pacific Brain Health Center in Santa Monica, California. Ryan has a bachelor's in exercise science and a master's in applied neuroscience, and is currently enrolled in the PhD in Leadership, Human and Health Performance Program at Concordia University of Chicago. Now, a copy of today's presentation slides can be found in the handout section of your toolbar. And if you have questions as we go through today's webinar, please type them in the questions section of your toolbar, and all questions will be answered at the end in the order they were received. All right, Ryan, take it away.
Thank you, Marianne. It's always an honor to work with MFA, one of my favorite organizations. And thank you so much to everyone for coming here today to learn more and listen in on brain health, exercise, and the integration of medical fitness and neurology. I'm not going to reintroduce myself because that will be redundant, so let's move on. So let's first talk about why we're here. Obviously, we're all interested and passionate about brain health as well as bodily health. And as health and fitness professionals, even those more medically inclined, we're interested in solving the problems that the world possesses in terms of medicine, health, and well-being. And one of those big issues is brain health. So we currently have a global issue surrounding brain health, and let's go over some examples of what that includes. One of the main things that you're going to hear about when it comes to cognitive impairment and brain health is a disease called Alzheimer's disease. In fact, now they're just calling it Alzheimer, so it doesn't have that possessive language. And Alzheimer's disease is just a form of dementia that happens to be the most common form. There's different statistics out there. These are 2020 statistics. I'm sorry for not updating those for 2022 or 2021. But a lot of statistics show that Alzheimer's disease makes up about 60 to 80% of most cases with dementia being defined as the loss of activities of daily living or the ability to maintain functional independence due to a neurodegenerative process. And so some of these 2020 statistics include an estimated 5.8 million Americans aged 65 or older are living with Alzheimer's dementia in 2020. 80% are age 75 or older, and 2/3 are women. And much more research is being done on understanding how and why women are more predisposed to Alzheimer's disease and certain aspects of neurodegeneration when compared to men. Some of that having a hormonal basis of aging. But certainly women's health is brain health, and there's more research coming out to justify that. By 2050, the number of people aged 65 and older with Alzheimer's dementia may grow to a projected 13.8 million. As new statistics come out every 6 or 12 months, that number seems to be getting bigger and bigger. In fact, all of these numbers are primarily due to population size and our global populations living longer. Alzheimer's disease is the 6th leading cause of death in the United States. The 5th leading cause of death among those 65 and older is also the leading cause of disability and poor health. Unless there's a treatment to stop, slow, or prevent the disease, by 2050, Alzheimer's is projected to cost more than $1.1 trillion US dollars. Now, this is not such a positive or optimistic viewpoint, but it is a massive problem. And that last statement, unless a treatment to slow, stop, or prevent the disease is developed, is a powerful statement I want us to sit with. And a lot of people think medication or stem cells or other types of treatments like brain stimulation, all those are exciting and innovative and definitely include some of the things that we're researching here at the Pacific Brain Health Center. However, many of the things that can modify this trajectory, as we'll find out, are lifestyle factors and things that are preventative. And exercise, according to the World Health Organization, is one of the most evidence-based things to prevent cognitive decline. So we have one of the biggest solutions, which is preventative measures, including exercise. And the people that are most likely to dispense that medication are right here in this webinar or watching this webinar. So I want that power to sit with you for a second there. But it's not just about Alzheimer's, dementia, or dementia. 35% of comorbidities, we're talking diabetes, cardiovascular conditions, neurological conditions, have cognitive complaints. So even people with knee or hip issues, people in pain, people who have fallen, there's usually some sort of cognitive component there. So even if it's not about dementia, cognitive health and brain health is still part of the conversation. 25% of older adults 65 and up have a condition called mild cognitive impairment, which is the mid-stage between normal cognition and dementia. And 11% of individuals 45 to 65, which is a big range. I know it seems like a small percentage, but it's a big range, have subjective cognitive complaints, which is essentially, I know that my memory isn't what it used to be, and therefore I think there's a problem, but not bad enough to go see a doctor about it. In terms of global prevalence, in terms of millions, traumatic brain injury, there's about 69 million people with traumatic brain injury, which you don't have to be knocked unconscious to have a traumatic brain injury. This includes any sort of concussion, but can also include other more severe types of traumatic brain injury. 50 million people globally have dementia, and 10 million people have Parkinson's. I want to emphasize this is not including statistics on mental health, depression, anxiety, schizophrenia, bipolar, so on and so forth. And so as we start to combine these statistics of issues surrounding the brain and mind, you can see this is a big problem. There's other conditions that also affect cognition and brain health. And some of these are not conditions, but they're factors. Medications, we're not saying medications are bad, but many medications can have a cognitive effect. Sometimes that's a necessary cognitive effect. Sometimes people are over-medicated, especially over adults. It's called polypharmacy, in which there's too many medications causing negative interactions with the brain. And seeing a geriatric psychiatrist, for instance, to optimize that medication management strategy would be a helpful thing to do, which we'll talk about later. Obesity, metabolic disorders, there's more research coming out demonstrating cognitive impairment and brain volumes being correlated with BMI, especially in those who are obese or have metabolic disorders. Cardiovascular conditions, the brain is a very blood-hungry organ, so naturally anything happening with the cardiovascular system will affect the brain. Cancer and chemotherapy, there's something called CRCIs, or cancer-related cognitive impairments. Some people just call it chemo brain. Neurological and neurodegenerative conditions such as Parkinson's disease and dementia respectively, and then mental health issues. So all of these things have a cognitive cost that we need to be aware of. So hopefully by the end of these slides, you'll understand that cognition and brain health is not just about Alzheimer's, it's not just about dementia. Everybody has a brain, even though you might theorize for certain parties that is otherwise. But everybody has a brain, it is an organ, and what happens down below can affect what's happening above and vice versa. In terms of the trajectory of cognitive decline over the lifespan, just like every other organ system in the body, it does decline with age, but steadily. And these top two green lines are really indicative of the normal aging process. So there's a steady, not too steep, but a steady decline in certain cognitive abilities and brain volume and brain function over the lifespan. Now, where according to the statistics, where many people will be, especially as they are 65 or older, is perhaps that light blue line, where it's sort of that subjective cognitive complaint. It's a little bit more accelerated than the normal line. And it's this preclinical phase, that subjective cognitive impairment. I know something is wrong. I know I don't feel as sharp as I normally do. It's not just because I didn't sleep well, or it's not just because I'm having a bad day, but this is recurring over days and weeks and months. And my memory or my organizational abilities or my attention is just not what it used to be. And this isn't due to a short-term event unless it was a traumatic brain injury or stroke or a microstroke. So it's a stage where the patient knows, but the doctor doesn't. And some people have different philosophies. Some people are very anxious about their brain health. They misplace their keys once, which is probably totally normal. Think they have dementia. On the other end of the spectrum, someone can have complete mild cognitive impairment undiagnosed, or dementia undiagnosed, or Parkinson's undiagnosed, and think everything's fine. And that's part of the normal aging process, none of which are correct. It's really somewhere in the middle. And this is why it's so important to integrate with medicine to classify where you are in this trajectory based on a variety of tests we'll go over. If this continues, there's a chance of conversion to what's called mild cognitive impairment, or MCI, which is cognitive change of concern to an individual or family member. Perhaps this is more severe. We're starting to notice, oh, they're having issues memorizing where they put their keys almost every day, even though it's recurrent. It's kind of the same environment, or parking the car, or driving, or managing finances, what have you. And this is where one or more cognitive domains are impaired significantly. So it could be amnestic mild cognitive impairment, which is a memory deficit like amnesia, amnestic, or it could be multi-domain. Or it could be executive, so they're having issues with organizing, planning, things like that. And multi-domain means it's more than one domain of cognition that's impaired. But because they have preserved activities of daily living, a lot of people might think, oh, everything is fine. They can still dress, they can still bathe, they can still operate their finances, even if it's with a little bit of trouble, yet they still have cognitive impairment. And many individuals who have mild cognitive impairment are not yet diagnosed with it because they're in the community and they may not be in a clinical setting. When they're in a clinical setting, it might be a little bit more down the line where it's about to convert to dementia. And so with people self-selecting to refer themselves or seeking out a neurologist and ask their GP, hey, I think something's wrong, can you refer me to a specialist? I'm not going to say it might be too late, because that's not true, but you might be further along that line than we'd like you to be. And certainly, as we'll find out, brain health is a preventative activity. These signs and symptoms are showing up decades before. Sometimes the brain is changing suboptimally decades before there's even a sign or symptom. And so the World Health Organization states that any older adult, 65 or older, should get a cognitive evaluation or brain health evaluation of any kind. It could be a subjective conversation with the doctor. It could be a brief test, naming animals and doing some counting, these brief cognitive assessments that might be done, all the way to a full-blown brain health evaluation consisting of MRIs, brain activity scans, and full-blown cognitive testing with a neuropsychologist, which is the type of workup we do here at the Pacific Brain Health Center. But any older adult, 65 or older, should get some sort of evaluation. Now, if MCI continues, there's a risk of converting to that red line, which is dementia, which, as you can see here, is defined as cognitive impairment severe enough to interfere with everyday abilities. And that has different severities, and there's many different types of dementia. There's Alzheimer's, there's Lewy body dementia, there's vascular dementia, there's mixed dementia, frontotemporal dementia. Once again, Alzheimer's disease being the most common form of that. Now, in order to positively affect this trajectory, well, which we're all interested in doing, there's something called cognitive reserve, which is really kind of a hypothesis. And the theory is the more full this cognitive reserve is, the longer you extend this trajectory and avoid neuropathologies like dementia. So how do we do that? Well, there's a lot of things that theoretically contribute to cognitive reserve. The percentage in which these contribute really isn't there yet in terms of the research. We're still learning more about how much they could positively contribute to cognitive reserve. I think personally the most important one is the one in the upper left, which is modifiable health factors, which includes anything lifestyle related: sleep, diet, as we'll talk about for the most part, exercise. Educational level does matter, but maybe not as much as we thought. Social support matters. If you have changed your social network based on the pandemic, you might find that it does affect your mental and cognitive health. Affect or mood states, of course, affect cognitive health. Stimulate activities and novel experiences, and cognitive training. So all of these things can contribute. I would argue the modifiable health factors are most important, but if you're very healthy and you have social isolation, that social isolation can have an impact on your brain health, or if you have depression or vice versa. Of course, those modifiable health factors can also improve mental health, but you see my point here. This is an integrated system. This is why I think working with allied healthcare professionals and working with people like health coaches who can go outside just that area of exercise, working with nutrition professionals, psychologists, things of that regard, getting integrated into the community. It's so much more than just the exercise program, even though that's what we're going to focus on today, because there's so many factors that affect brain health. I'm going to throw around some words and terminology, so let's quickly get familiar with some of these key terms. Neurons are just brain cells. They're cells in the brain. They're called neurons. They have a lot of components that other cells have, like mitochondria, nuclei, etc. Synapses are the connections between those neurons that basically send neurotransmitters back and forth, which are chemical signals. Behavior, when we're talking about behavioral outcomes associated with the brain, we're talking about cognition, which is mental functions like attention, memory, processing speed, executive functions, reaction time. And so cognition is a behavior of the brain. It's how you demonstrate your interaction with the outside world, as is mood. Mood is a behavioral outcome. There's also signaling factors, whether they're in the brain or come peripherally from the body and into the brain through the blood-brain barrier, like growth factors, hormones, proteins. There's different brain regions like the cerebellum, the temporal lobes, the frontal lobes, and these can be changes in the regions of the brain, so a change in the frontal lobe or a change in the hippocampus, or it can be a functional change because the brain is such an electrical organ. We can have a change in brain activity that then changes cognition or mood without changing the physical structure of that altogether. More research is coming out on these functional brain networks, so it's less this part of the brain does this and this part of the brain does this in this isolated anatomical model, and more like these different parts of the brain activate in this network in this type of task. And so there's the central executive network and the default mode network, and there's many other networks, but we won't get into that too much. There's glial cells, which are the support structures surrounding neurons and other components of the brain. And of course, there's a blood supply to allow blood into the brain through major arteries all the way to microvasculature structures throughout the brain. We'll skip this one here. Different changes to the brain can occur. This depends on the type of neurological or neurodegenerative condition. So here you're going to see some common conditions listed off here, from Alzheimer's disease to Parkinson's to Huntington's to MS. And you can see as the shaded keys here. So for example, with Alzheimer's disease, which is shaded in blue, this can affect certain regions of the brain. And some of these boxes here are common classes of medication that are prescribed for these types of conditions. It's not necessarily important for you to memorize this, just to understand that different conditions affect the brain in different ways. And therefore, certain interventions, including medication or exercise, can also affect the brain in different ways. So I'll give an example. With Parkinson's disease, the basal ganglia, shown here as the substantia nigra, which is a component of the basal ganglia, is affected. This is an area of the brain responsible for dopamine production. It's also responsible for things like procedural memory, such as walking, swallowing, speaking, and other types of movement. And so more research is coming out showing that skill-based exercise, which acts on that basal ganglia, on that structure of the brain that's affected by Parkinson's disease, can improve outcomes. So I'd love to see a future where there's very specific exercise prescriptions for different phases and stages of each of these diseases, so that we can be as specific with our exercise prescription or plan as we would be targeted with medication. One thing that you can appreciate with these neurologic conditions and neurodegenerative conditions is these shared kind of relationships among gait or walking, balance, cognition, and activities of daily living. This is kind of going to be more apparent for neurological rehabilitation, such as neurological physical therapists, occupational therapists, and speech-language pathologists. But also for fitness professionals, it's important to know that there are changes in one or more of these systems with most of these diseases, and that we can actually create exercise programs that maybe help target or improve or support the therapeutic or rehabilitation goals in one or more of these areas. Now, you might be wondering, well, that's all kind of interesting, but also somewhat depressing. How is it possible we could actually make a difference? And I'll just provide this one principle, which is called neuroplasticity, which is thrown around quite a bit. But neuroplasticity simply refers to the brain's ability to change in response to experiences. Just like the body can change, the neuromuscular system and the skeletal system can change, the muscular system in the body can change in response to stimuli such as exercise interventions, as can the brain. And there's some of these neuro myths out there that you can't teach an old dog new tricks, which is very ageist, or you can't change your brain after your 60s or 80s or what have you. I don't know what the latest one is. These are hopefully being consistently debunked. But neuroplasticity is well available into late adulthood. However, what is less discussed is the amount of change that's required to elicit that change. And what stereotypically can happen with older age is retirement, in which there's some research showing that earlier retirement increases the risk of cognitive decline because we're removing a very significant cognitive stimulus, unless your job is so exorbitantly stressful that it's causing lessened brain health, which is quite a possibility. But it does require a daily cognitive load. There's social interaction, there's cognitive demands, there's new things that might be happening. So the removal of cognitive stimuli daily is basically retirement. And then statistically, older adults, about 80% of older adults are not meeting the minimum recommendations for exercise. And so with lessened cognitive and physical stimulus, it makes sense why we might have so much of these brain and mind issues, especially in older adults. And so with age, we actually should be doing more cognitively and more physically to offset this. So let's talk about some lifestyle factors as it relates to exercise and brain health. So before we just get into exercise, I want to honor and acknowledge some of the other lifestyle factors that do have a very sound evidence basis for improving brain health and cognition. Sleep is getting more and more research. Once again, this is where I think health coaching is so important, working with sleep medicine, sleep psychologists, those who specialize in cognitive behavioral therapy for insomnia. There's a sleep coaching certification for health coaches out there now. Sleep and brain health are incredibly important. Diet, stress management, medication management, comorbidity prevention and or management, cognitive stimulation, and social support. This should sound familiar to you. It's a more expanded version of those modifiable health factors that were part of that graphic on cognitive reserve. And so the more things that we can help with in this regard on this slide, I think the better. Now, you don't want to be the only person. Of course, you want to be referring to allied health professionals because this is a team effort here. And certainly this is part of what we do at the Pacific Brain Health Center, referring to nutritionists and health coaches and sleep doctors and psychologists and specialists. There's so many things to be done. Support groups in the community, working with community health clinics and working with community gyms and personal trainers and physical therapists and psychiatrists. It can be overwhelming, but it's really an opportunity to help individuals connect the dots to have a comprehensive approach and establish their own team as it relates to their brain and body health. Obviously, there's none of these things here that aren't going to help with the body as well, so that's something to note. In terms of mild cognitive impairment, there's actually a very sound basis of evidence for these types of interventions helping, ideally in a multi-domain manner, meaning we're doing more than one thing as opposed to just doing one thing and stopping there. Certainly, one of the things that can help tremendously with MCI, which we're going to talk about, and to slow that conversion to dementia or prevent it altogether, perhaps, is exercise. And as we'll talk about, the minimum recommendations are 150 to 300 minutes per week. And that might be tiresome or obvious or redundant to hear again, but there's more research showing that those minimum recommendations do have brain health benefits. So that's good to know. Obviously, managing mood through stress and social engagement and things that are meaningful and enjoyable. Nutrition, very important. You've heard the Mediterranean diet thrown around a lot. There's also one called the DASH diet, which is diet for hypertension. And if you think about the dependency of the brain on the cardiovascular system, that makes sense that that would be helpful. So there's actually a very well-researched diet called the MIND diet, which is a combination of the DASH diet for hypertension and the Mediterranean diet. There's more and more popularity and attention for ketogenic diets. And actually, there's more research coming out for individuals already cognitively impaired or already having a neurological condition, that ketosis might potentially be helpful. Cognitive training. By cognitive training, I actually mean two things. It could be brain games. Brain games get a lot of flack. They're kind of like supplements. We'd like to think that they're helpful. There's more research coming out that they could be helpful. They may not transfer to things in real life, but probably better to do it than to not, but certainly not the biggest priority. But also cognitive stimulation, going to museums, going to music shows, engaging in hobbies, art, things like that, whatever suits your fancy. Sleep hygiene, especially the treatment of sleep apnea. So many people are undiagnosed or not diagnosed with sleep apnea or sleep disordered breathing when they've had it for a long time. And once again, because the brain is so oxygen dependent and blood dependent, we need that blood flow and that oxygen delivery during sleep. And things like brain shrinkage and cognitive impairment have been linked to untreated sleep apnea. That could be positional sleep apnea, central, peripheral, and that's why it's important to refer to a sleep doctor. And also medication management. Well, we're going to rush through some of the benefits of exercise in the brain to get to the parts where we talk about integrating with medicine a little bit more. Exercise can help with all levels of the brain. I break it down here into 3 levels. The micro level, which is the neurons, the synapses, the growth factors, the blood vessels. Much research has been shown, mostly in animal models and more in human models. It's just very difficult to get a human to do CrossFit. And immediately after that CrossFit intervention, kill them and slice their brain. So of course we bias to rats. But some of these things we assume are happening, such as the creation of new neurons in the brain. That is sort of a debated thing in the adult human brain. But certainly we know that there's some aspect of neurogenesis happening in certain areas like the hippocampus and olfactory bulb. We don't know if that translates to other areas of the brain. But definitely there's other types of neuroplasticity occurring in the form of synaptogenesis, which is networks forming or being modulated by exercise and physical activity. There can be the release of things like BDNF, or brain-derived neurotrophic factor, insulin-like growth factor, vascular endothelial growth factor. These are all growth factors that get released with exercise, perhaps different concentrations with different types of exercise, and tell the brain to do good things: survive, proliferate, grow, protect, etc. At the macro level, which is if you held your brain in your hands, and you can actually get brain scans, a volumetric MRI of the brain, or you can get a brain electricity scan. The macro level is insinuating that there's changes in brain regions, brain networks, or the brain as a whole. So it could be increases in global gray matter volumes of the brain, or an increase in the size of the hippocampus, or just more improved functional connectivity of the central executive network, or increased activity of the frontal lobe. These are all things you might read in research, but whether it's functional and or structural, depending on the intervention in the study, research has found that exercise can impact the brain globally, specifically, functionally, so on and so forth. Probably most importantly to us, I think the rest of this stuff is very cool, especially for me, but probably most important to us as health and fitness professionals, those that are more medically inclined, is that we're looking at behavioral changes, things that you can see and feel and that you may be able to observe in others, or at least others can observe in themselves, which is improvements in cognition. I think we'd all probably agree that we feel a little bit sharper after exercise, especially when we're doing it for weeks and months. And we feel an improvement in mood. That could be both short-term and long-term. Of course, if we feel good, if we see these benefits, the likelihood that we continue to participate in physical activity and exercise should increase. So it's not just about blood flow. It's not just about brain-derived neurotrophic factor. Exercise can improve brain health at multiple levels here. In terms of the short-term benefits of exercise on the brain, there's a great review by Dr. Wendy Suzuki and Dr. Basso, her colleague, from 2017. Dr. Wendy Suzuki has given one of the most popular TED Talks on exercise in the brain. And this kind of shows what happens in certain time increments after you stopped exercise. This was a very broad review and really reviewed any duration or intensity of exercise from 5 to 90 minutes to low to high intensity. But let's just say it's an average of 15 to 20 minutes at minimum of about a moderate intensity of exercise. Once we stop exercise for up to 15 minutes after ceasing that exercise, there's an increase in activation of the prefrontal cortex. And for up to about 60 minutes or an hour after exercise, we release all these beneficial neurotransmitters like GABA, lactate, glutamate, norepinephrine. For up to 2 hours, there's a release in a presence of dopamine, cortisol, and serotonin. We're talking about the non-pathological brain here. For up to 60 minutes, there's an increase in the release of brain-derived neurotrophic factor. And for up to 30 minutes, there's an increase in these brain waves of delta, theta, alpha, beta. And so it makes sense because exercise is an excitatory activity. So of course it excites everything associated with that. For up to 2 hours, because of all these things occurring, there's prefrontal cortex dependent cognitive functions, which include things like planning and organizing and complex attention and short-term memory and impulse control. So you might feel this short-term boost for up to 2 hours after exercise, maybe a little bit longer for certain more complex cognitive tasks. For up to 3 hours after exercise, there's this marketable improvement in stress reduction. And for about 24 hours, there's an improvement in mood states. So when people say, oh, I'm going to use exercise to target this neurotransmitter, target this brainwave, that's really hard to justify because all of these things are happening and the brain is very complex. It can't be isolated and targeted in that way. However, we will talk about how certain interventions might contribute to certain brain regions. We can't ignore the positive benefits of exercise on mental health: increased energy, improved confidence, increased self-esteem, improve sleep, which is an important one, both quality and quantity, improve mood, and reduce stress, as we learned in the previous slide. But let's talk about some specific brain regions and how exercise might affect these brain regions. So shown here, we have the hippocampus, which is in red, and that hippocampus is responsible for memory formation, learning. It's kind of located in the temporal lobes underneath the ears, and research has shown that we can actually use exercise, perhaps specifically aerobic exercise, but other types of exercise as well, like resistance training, to increase the structure and volume of this area of the brain. And this is important because this area of the brain starts to atrophy or shrink or decrease in function as a response to a suboptimal neurodegenerative process. And so this is attractive for individuals with mild cognitive impairment, or those starting to notice memory issues, or older adults who just want to maintain and preserve memory function and formation. And so this area of the hippocampus has been widely studied. In fact, research shows that sedentary behavior, chronic stress, sleep deprivation contributes to atrophy or shrinking of the hippocampus, as if the hippocampus was like this barometer for lifestyle as it relates to brain health. It's not just aerobic exercise that contributes to the structure and function of this area in a healthy way. It's really all forms of physical activity, but it's been researched for so long that a lot of people just use aerobic exercise as their interventions, and a lot of other researchers will replicate that, and therefore there's big reviews on that type of exercise. But once again, it's also resistance training in certain areas of the hippocampus as well as physical activity, and many of these studies also report some sort of improvement in cognition in tandem with this change, such as memory changes. There's other systematic reviews showing that resistance training improves the structure and function of the frontal lobe, which is right in front of your head. If you put your hand on your forehead, your frontal lobe is the frontal third of your brain. And there's lower white matter atrophy and lesions as a result. And also because this category of cognitive functions called executive functions, which is, once again, impulse control, short-term memory, cognitive flexibility, kind of responding to unexpected circumstances, problem solving, planning, organization. Those are all executive functions. You can kind of think of it like the CEO of the brain. Because the executive functions seem to be localized to this region, if this region improves in structure and or function, it's quite logical that you may improve or see improvements in executive functions. Now, you could do this just because the brain activity is changing and the brain is more efficient, but you could also see it in terms of the preservation or increase in brain volume. So I think it's interesting that resistance training, stereotypically, you think of a meathead who lifts a lot of weights, and stereotypically that's a football player that isn't very smart, right? That's the stereotype used in comics and all sorts of stereotypes in TV for however long, and probably still is utilized. Yet strength training, specifically resistance training, seems to improve the structure and function of the frontal lobe, which is very cool. Earlier, we talked about an example of what is the neuropathology of Parkinson's disease, and we talked about this area called the basal ganglia, specifically the substantia nigra, but there's also other parts of the basal ganglia like the globus pallidus, and it's near the thalamus and cerebellum. And so motor fitness, so not just aerobic, not just resistance, but motor fitness, which is probably not talked about as much, which includes anything with coordinative or proprioceptive demands, or things that you have to learn movements and sort of react to things in sports, dance, martial arts, mind-body activities. There seems to be an improvement in the size and structure of the basal ganglia. There's a little bit of research that this might translate to the cerebellum, which coordinates movements and is responsible for complex planning of movement and learning of movement. But more specifically, the basal ganglia, it's actually been shown where people studied in which people take an aerobic exercise intervention and then they take a neuromotor intervention that's more coordinatively complex or motorically complex, and they find that while aerobic exercise helps the size and function of the basal ganglia a little bit, it's really the motor or neuromotor or coordinative fitness that really improves the size and or function of the basal ganglia. And because this region of the brain is affected in Parkinson's, this still applies to Parkinson's. So skillful exercise would be helpful for individuals or persons with Parkinson's. And maybe that's why things like boxing and dancing are recommended. And I'm even involved in a nonprofit called Ping Pong for Good, where we facilitate locally ping pong classes for persons with Parkinson's disease, because it's a very skillful exercise modality. And certainly through these skill-based pathways, those seem to mediate cognitive improvements. There's a connection between the thalamus to that prefrontal cortex, which is associated with executive functions. And so you have to really use your brain and pay attention when you're learning skills. So skillful exercise seems to improve certain types of cognition and structurally seems to address the basal ganglia. So sports, dance, martial arts, from ping pong to Tai Chi, including things like cognitive motor dual tasking, which we will briefly define later. So this is an imperfect slide. We will not spend a lot of time on it. I know I'm going fast with this stuff, but my idea with this slide is maybe different types of exercise can affect different regions of the brain, or more of one region than another region. And if we're going to have a whole brain exercise program, if that was a concept, maybe we want a variety of activities. We want some aerobic, we want some resistance, we want some neuromotor. There's, of course, many different types of all three of those categories of exercise, but perhaps a structured variable program of this exercise might be helpful. And if we have a neuropathology or a neurological condition where one or more regions of the brain are specifically affected, maybe with more research we can target these regions. So once again, we have aerobics, strength, and neuromotor, and there's a lot of different types of each one. There's steady state interval training, different intensities. With strength, you can do functional training, closed skill training with exercise machines, body weight strength. There's mind-body exercise, sports, dance, martial arts, dual tasking, and exergaming, which is how I got addicted to exercise, was through games like Dance Dance Revolution, the Nintendo Wii. My latest kick is using virtual reality exercise, playing games like Supernatural or Box VR, or doing things in virtual reality like ping pong, which I'm rather crazily obsessed with. But it's a combination of these types of activities that I think will really help general brain health, and really even for special conditions. It's kind of recommended for everybody. And this isn't really new. The Physical Activity Guidelines for Americans, second edition, does list these three modalities off, but the translation into the real world for fitness professionals recommending this, for medical professionals recommending this in this way for brain health specifically, really hasn't happened yet. So that's a goal of ours, to change that. There's, of course, different types of activities, from closed skills to open skills. I think closed skills are most of what we think about when we think of fitness or exercise, or when most people think of fitness or exercise. They're stable, they're predictable, they have a clear beginning and end, whereas open skills, usually associated with a neuromotor fitness modality like tennis shown here, the environment's constantly changing, the movements have to be continually adapted, it's externally paced. And both are good for the brain, yet open skills might improve certain cognitive functions when compared to closed skills. In reality, both are important, but I see that most people in the fitness industry aren't incorporating open skill. And so here's a nice breakdown of the three or four different kinds of exercise here. Aerobics and strength constitute physical training that improves the brain through metabolic demands, whether that be neuromuscular demands or actual cardiometabolic demands. And then we have motor training, which can include balance and coordination, and improve the brain through neuromuscular demands. There are certain types of activities like tennis that combine both. You, of course, get your heart rate up while having a neuromuscular demand. But it's not saying one is best for the brain. We actually want a combination of physical, motor, and specific skill training. There is something called dual tasking, where you're doing two things at one time. You're sort of artificially creating the simultaneous cognitive and motor demand found in skill-based training. I don't like the example given here, but exergaming and what I do at the Pacific Brain Health Center incorporates dual tasking, both technologically and non-technologically. Essentially what that is it's training individuals to perform two tasks simultaneously, one primary, one secondary, that can be performed independently, measured separately, and have distinct goals. But dual tasking is present in sports, dance, martial arts, mind-body activities like yoga, exergaming, and dual tasking, which I teach people how to do and how to incorporate. And there's also technologies like Reaxion, SmartFit, Blaze Pods, many other technologies out there trying to harness this dual tasking or reactive training that more research is needed, but seem to be promising in targeting these dual task abilities. And actually in older adults especially, there's been some systematic reviews finding that dual tasking improves cognition greater than no intervention. No surprise there. Dual tasking improves cognition better than physical exercise by itself. Dual tasking improves cognition more in older participants or those affected by neurological or neurodegenerative conditions, MS, Parkinson's, stroke, etc. And dual tasking appears to last longer than single tasking effects. So this is very interesting. It doesn't mean it's better than everything else, but dual tasking may be an important ingredient in an exercise plan for those interested in brain health and cognition. Here's some more research showing that dual tasking leads to more efficient frontal lobe activity and therefore executive functions, as we talked about with resistance training. So it's interesting that resistance training and dual tasking seem to affect certain regions of the brain similarly, perhaps through different mechanisms. The brain is very complex, so it's not just the prefrontal cortex. There's many different subregions. But I think that's pretty cool, and we might think about, okay, maybe how can I make my resistance training program more cognitively demanding, for instance. And one of the theories that's been posited as to why dual tasking might be good for the brain is that there's a adaptive capacity model, which is an evolutionary neuroscience model posited by Dr. David Reichland and some of his colleagues, showing that when individuals were hunting and being cave people, they had to use their executive functioning, their problem solving, their cognitive flexibility, their decision-making capacity, their planning, their sensory and attention systems, their spatial memory and navigation systems, their motor learning control systems, all at the same time. They did not catch their prey being on a stationary exercise bike, and they certainly did not catch it right in an essay. They had to do a lot of things, physical and cognitive, at the same time in an unpredictable manner. This seems like an open skill if I was to classify it as that. Tennis is not the same as that rush of hunting an antelope, but I think you can get the point here. So, are these general recommendations for brain health enough? Well, certainly the 150 to 300 minutes or the 2.5 to 5 hours a week recommendation of moderate to vigorous intensity does include brain health benefits, as the second edition states. However, there is some additional research showing that if you add neuromotor training, if you add strength training, if you get more minutes in there, that you can get additional benefits. There's also research showing that when you do more than one type of exercise, so aerobic and resistance or neuromotor and resistance, you're going to slow the progression of cognitive decline more than just one modality. So a lot of people ask, what's the best form of exercise for brain health? I said the one that combines multiple modalities. And then a systematic review by Dr. Joyce Gomez-Osman and her team from about 2018 or 19, I believe, showed that 52 hours of exercise led to significant improvements in executive functions and processing speed in older adults, regardless of modality. So I'm almost contradicting myself here. This systematic review wasn't super sensitive to types of exercise, and exercise researchers do a pretty bad job of giving the specific acute variables of the frequency, intensity, type, and duration. However, it seems it might not matter what kind of exercise it is, just get up to 52 hours over any period of time, depending on your duration or frequency, and maybe that's the minimum recommended dosage to achieve significant cognitive benefit. Ideally, you don't stop there, you keep going, but that's an interesting dose response result from a systematic review. So what are the elements of a brain healthy exercise program to review? We want a minimum of 150 minutes per week. Like I said earlier, 80% of older adults are not meeting this recommendation. So while it seems basic and simple to us who are biased, I think using sound behavior change strategies to help get people there in medical settings to community settings to our own practices is, there's a call to action for that, most certainly. Multi-domain programs on top of that, which would help us reach those minutes, combining aerobic resistance and neuromotor, and incorporating a combination of low, moderate, and high intensity. So Tai Chi and yoga can improve brain function and structure, yet it's a low intensity. So can walking programs. We also want moderate intensity. We also want high intensity. I think people are currently enamored with high intensity interval training, saying it's the best for X, Y, and Z. But the reality is there's a variety of different intensities that demonstrate brain health benefits. One thing I see missing from a lot of exercise programs intentionally is incorporating open skill exercises or exercise modalities with cognitive demands, such as if you've been working with a client for about 10 years and you haven't updated that program, there's no novelty, there's little cognitive demand, it's all almost procedural memory by now, it's probably time to update that. And most importantly, perhaps, is designing for enjoyment and behavior change. We can't just tell people to do this stuff. We have to use behavior change strategies in order to do this. So I talked fast. I wanted to get through that quickly so that I can get to what I think is very exciting stuff, which is what are some guidelines for integrating medical fitness with neurology? Not just neurology, this applies to allied health professionals in general. Some of this information will be redundant and it's not entirely original, but how might we integrate with medicine, specifically in relationship to brain health? So what's the problem? Well, I'm making some broad assumptions here, and please don't take this as a personal attack. If none of these statements apply to you, that's fine. I'm just thinking about the fitness industry as a whole. And MFA, I think, is a biased sample of people that already know the importance of medical fitness integration, sort of make very specific steps and actions in order to do that better. But just work with me here. Fitness professionals typically are not trained to interface, interact, or collaborate with allied healthcare professionals. The average client works with several health professionals at any given time, but rarely do they speak to each other. Clients may feel overwhelmed attempting to understand and coordinate their own care. Gaps may exist within a client's health and lifestyle plan, potentially causing deleterious effects or reducing lifespan, i.e. a missed opportunity within a medical management or engaging with lifestyle interventions. And health and fitness interventions professionals, including myself, have ego, insecurity, and various perceived senses of value. But before we get into more of the psychology around this from our own perspectives, what are some examples of allied healthcare professionals? Quite obviously, we have physicians, PCPs or GPs. We have specialists. That could be anything from an ophthalmologist to an endocrinologist to a neurologist, psychologists or social workers, neuropsychologists. We have rehabilitation clinicians, physical therapy, occupational therapy, speech language pathology, chiropractors, athletic trainers. And we have health, fitness, and lifestyle professionals, acupuncture, massage therapy, fitness, yoga, Pilates, Tai Chi, health coach, nutritionist, naturopathic doctor, functional medicine doctor. I could go on. And so the question is, who is responsible for helping a client or a patient navigate all this stuff? Well, I think there's a shared responsibility, and it's less about passing the football, and it's less about saying, I'm the one that's going to be the one to help you navigate this, and it's less about I'm the most important one in the mix, and more about recognizing that you just play a role on this individual's team. Specifically for brain health, and I'm using the Pacific Brain Health Center's model as an example of this because we have all of these individuals, neurology, general or specialty in neurodegenerative, such as dementia neurology or general neurologist, neurological conditions or movement disorders neurologist, perhaps one that focuses in multiple sclerosis or Parkinson's disease, and neuromuscular neurology. At the Brain Health Center, we have all of these. Neuropsychologists, which are trained to assess cognition. Psychiatry, if we're talking about older adults, perhaps geriatric psychiatry, gerontology, nurse practitioners, and health, fitness, and lifestyle professionals. So at the Pacific Brain Health Center, we're blessed to have all of these. That's not realistic for everybody, and usually these people are scattered throughout a community and not integrated. So it's good to know that these members can play a role in your client's or patient's brain health as allied healthcare providers. Now, there's different assessments for brain health. There's neuroimaging, which is getting a picture of the brain, an MRI, a quantitative EEG, a PET scan. There's electrophysiology using EEG or EMG. There's cognitive testing, which could be on a computer or it could be pencil and paper cognitive testing with a neuropsychologist. There's performance-based measures that a PT or OT might collect. There's physiological measures like heart rate, blood pressure, things of that regard. There's subjective reporting with people filling out questionnaires about their mood and their cognition. And there's general health assessments, things that have been shown to affect brain health. So getting your eyes checked, getting your ears checked. Untreated hearing loss can be contribute to dementia by about 10%. The vestibular system, we use smell tests here at the Pacific Brain Health Center because that's linked to neurological function. Obviously, cardiovascular health and working with individuals that are specialized in that, and even blood markers, whether it's finding certain blood markers like vitamin D or vitamin B12 that are out of range that need to get in range for better neurological functioning. These are all things that are important to consider and have a relationship to neurological health and therefore brain health. This is less relevant directly to us, but this is the physical activity vital signs, and in some medical records, this exists, but many doctors don't use this. They may not even know about it. But collecting information about physical activity in medical care is something that should, I think, be standardized and normal. I think a lot of doctors, if they know exercise is important, they might generally promote it or generally ask about it. But the physical activity vital signs is on average, how many days a week do you perform physical activity? On average, how many total minutes? Then you get the minutes per week or the physical activity vital signs, the PAVS. And then, of course, the intensity. Is it light, moderate, or vigorous? I think if this information was more regularly collected, therefore we could say, hey, I think you need to increase your physical activity. Either I'm going to promote it through introducing you to programs, giving you education, giving you resources, or referring you to a personal trainer or physical therapist or a movement or fitness professional that I know has this specialty in brain health or I know is interested in medical fitness. Of course, we have to consider our scope of practice. Credit to ACE and IDEA for this resource from 2001. But just to review, our scope of practice is to receive. Yes, we can co-create, but to receive exercise, health, or nutrition guidelines from physician, physical therapist, registered dietitian, screen for exercise limitations and identify potential risk factors, refer clients to an appropriate allied health professional or medical practitioner, design exercise programs, document progress, and report progress to allied health professionals, empower individuals to begin and adhere to their exercise programs, and recognizing what is within scope of practice and always referring clients to other healthcare professionals when appropriate. I think about 99% of what the fitness industry actually does is just facilitate exercise sessions. However, if you really read and study these, it's not to make your job harder or give you more work, but this is part of our scope of practice that I think we should be exercising. So what is an example of how you might actually incorporate this into your practice? Well, you have an assessment of your client's goals. This could be a new or existing client. You have your assessment battery, whatever that might include. And part of that assessment battery is, I think this is the most important part, who are you already working with? Identify the existing allied healthcare professionals. From there, determine their biggest needs. When you identify those existing allied healthcare professionals, if they're existing, if it's appropriate, and if there's a good reason for it, you should establish or attempt to establish communication with that allied healthcare professional. If there is a gap in that team, they need to see a physical therapist, they should go see a neurologist about their brain health. Consider suggesting the referral. You are not creating the referral, you're not generating it, you're not putting it in their medical record system, and you are not a doctor, at least I don't think you are, but you're suggesting it. You're suggesting they talk to their doctor about getting the referral. Of course, always work with stakeholders and work within your scope of practice to do that. There's a little bit of a psychology to this. We might feel threatened by other providers. They're doctors, I'm not, thinking they could potentially affect our business negatively if they're competitive or what have you. We might feel insecure thinking that we can provide everything we need for our clients. We're the hero of this journey. We are the expert, what have you. We might feel inadequate that we don't know enough to interface with allied healthcare providers, that we might say something that's not true or make a mistake. And we might feel overwhelmed. I'm just training people. I don't have enough time to do this, thinking that we don't have enough time to network or collaborate. Simultaneously, when I hear one or more of these things, individuals are struggling for referrals, and this might be why. Referrals to them, that is. And so I think if we can overcome these things, you can establish a very robust medical fitness practice because you're willing to put yourself out there and overcome these psychological barriers. What do you need to be prepared? Obviously, and ideally, an NCCA accredited personal training certification, in addition to any additional qualifications, specializations, degrees, insurance, etc. Have a professional resume, have a professional website that's up to date and isn't from the 1990s, use informed consent, liability, fitness assessment, health and medical, and PAR-Q plus forms. I can't tell you enough about how many times people are missing one or more of these things just out of going through the motions of working. I think it's important to keep these things up to date. In order to network with allied healthcare professionals, if you just Google Health and Fitness Professionals Action Guide and Exercise is Medicine, this is an Exercise is Medicine resource, you will find a much more in-depth resource on this. I just attempted to summarize it here. You want to create media kits, identify who your contact is, ask to provide materials and presentations, be polite with your follow-ups. I hear all the time, oh, I called a doctor's office once, I never heard back, so they must suck. They must not be interested. I didn't hear back from them. You need like 5 to 7 outreach mechanisms in different ways in order to really get some sort of feedback. Not all the time, but try more than twice or 3 times, please. Establish contact with allied healthcare professionals, send monthly or quarterly updates unless it's annoying or exhaustive or it becomes too much. You just want to stay in contact with people, establish rapport and a relationship. In terms of preventative referrals for brain health, here are some things that I think are important to be both preventative and if someone's presenting with cognitive impairment or neurological condition. Sleep medicine, cardiology, neurology, ear, nose, and throat or ENT for an assessment of hearing and vestibular function, and ophthalmology for an assessment of vision. All of these things are important. I think a lot of people missing one of these things might end up with untreated hearing loss or untreated sleep apnea or unmeasured brain function or structure or something of that regard. So, in summary, network and collaborate with allied health professionals, pursue additional education specializations, enhance your marketing, your clarity, your professionalism, connect and work with these allied healthcare professionals, have the client drive conversations around their goals, the vision for their health, and how their professionals connect. I tend to bias within brain health. I think these things are applicable to any sort of outcome. But if we are to integrate with neurologists or neurology or brain health associated providers, I think all of these things are needed. So in terms of integrating with fitness and healthcare, You got to identify the population of interest, whether it's Parkinson's, older adults, mild cognitive impairment, multiple sclerosis, assess the current evidence base, which I've done for you in my course, which I'll talk about soon, partner with relevant healthcare professionals, create evidence-based programming, which I can also help with, educate staff in relevant education, deliver programming to that target population, iterate, and then engage medical, academic, and community partners. And that's how I think we're going to integrate with neurology. As a case study, we have individuals with cognitive concerns or cognitive decline. There is really good evidence of exercise in neurological and neurodegenerative populations. We partner with an outpatient brain health center, which I happen to work for. We create population-specific exercise prescriptions. I work hand in hand with a physical therapist and a speech-language pathologist. We deliver the programming to the target population. We iterate it. We hire, educate, partner, and facilitate. And we engage with medical, academic, and community partners. So not to be redundant, but this is exactly the model we have applied to create a medical fitness program here at the Pacific Brain Health Center. That is all I have for you. I know I talk fast. I know I talk a lot, but we have 5 minutes left for questions. Should you want to follow me on Instagram, here is my handle, glatt.brainhealth. Should you want to email me for whatever reason, rglatt8@gmail.com. And if you're interested in learning more about brain health and exercise, I do have a 10-hour online self-paced course currently sold by the Functional Aging Institute and the American Council on Exercise. I always recommend, if you are not certified to work with an older adult or have a specialty in that, I highly recommend ACE's Senior Fitness Specialist, which is currently bundled with my course, the Brain Health Trainer course. That's the best deal out there because you get 2 certifications for one. But if you want to learn more about my course individually, you can go to brainhealthtrainer.com. And if you were so inclined, this is a code for 50% off that course, which is brain, all caps 300. Should you have any questions or issues, please do not hesitate to reach out, and we'll pause for questions. Thanks so much for your attention.
Awesome. Well, thank you, Ryan. That was amazing. I think I took 1,000 notes. We do have a question from Susan, who wants to know any exergaming equipment that's affordable and portable for PD that you can recommend?
Yeah, great question. I think affordable and portable is relative. When we say exergaming, we're thinking like Nintendo Wii, things like that. There's a product out now called Gin Home, modeled after the product Gintronics, which just uses a webcam on a computer to track your body movements like the Kinect, and you can play different exercise games. That's relatively new and hasn't been studied in response to cognition or those in Parkinson's. I'm currently recommending it. It's possible that it could be covered by insurance if used by a physical therapist for remote patient monitoring codes. If you want more information about that, you can email me. I hope I don't get 300 emails about this one product because I don't work for them, but I think it's a great product. Certainly there's reaction lights, blaze pods, fit lights, the SmartFit. SmartFit has these pods that are individual targets with various cognitive decline. Reaxine has various lights as well that can be used called Reax lights. There's also apps. There's one called Clock Yourself. There's one called Switched On that can generate stimuli on an iOS or Android device like arrows, colors, numbers. So while not all those are classically exergaming, those are all examples of portable and scalable devices. Technology is awesome. I think it's going to get, we're going to have much more tools in the toolbox. I have several clients with Parkinson's disease that bought an Oculus Quest headset for virtual reality, do their boxing, do their ping pong, do their meditation, do their Tai Chi, all in that. Of course, there's a fall risk, there's cyber sickness potential. Not all of these are appropriate for everybody. It really does depend on who you're going to give this to, what their level of cognitive and physical function is, what your budget, what you mean by portable. I know that's a lot. I wish I had that list here. I do mention some of those resources in other presentations. Should you be further curious, I'd be happy to oblige via email.
Okay, so Susan just has a quick follow-up. Did you say GenCam, G-E-N?
Ginhome, J-I-N-H-O-M-E.
Okay, I hope you got that, Susan.
You might also use the search term Gintronics, J-I-N-T-R-O-N-I-X. That is one specific extra game. The rest of them not necessarily are extra games, but tools to generate somewhat random stimulus in the context of dual tasking or more cognitively enriched or reaction-based exercises.
Awesome. So Ruth says, thanks for the great info. Love your enthusiasm. She also says, what about other specific paced exercise for folks with PD?
Paced? Was that the word?
PACED, P-A-C-E-D.
I don't know what you mean by paced, but I will
Okay.
just re-summarize that skillful exercise, dance, sports, more martial arts, specifically things like dance and boxing and ping pong and things like that are helpful. I mean, there's a lot of ways to pace things. You could pace the choreography, you could pace the speed. One thing that keeps coming up in Parkinson's research is intensity. Of course, that's managed intensity, not intensity for you, but intensity relative to them, both metabolic intensity, and so there's different pacings to different types of intensities. So probably a complex answer to what was probably intended to be a simple question. Happy to answer that further via email.
Awesome. Let's see. She said Ruth says there is research about a specific paced cycling. She said we have done
Oh, I
hula
see.
hooping.
Okay, sure. Yeah, so if cycling at a certain like RPM or something of that regard, that makes sense. I think maintaining that rhythmic movement, there's an external focus of RPMs, just like there is with heart rate, for instance, for targeting heart rate zones. If you have that feedback, it's almost like biofeedback in a way. They have an external focus. They're keeping their revolutions per minute consistent. I could see the value in that. Yeah.
Oh, awesome. Yeah, I'm thrilled to see Ruth mention hula hooping. I've been a hula hooper for many years.
Not aware of any research on hula hooping, but would be hard to doubt that it might be beneficial.
Very cool. And it's fun. So Jeanette said, in the beginning of your talk, you mentioned cognitive reserve. How is
Yeah.
this measured? And is there a standard that a person in decline can be compared to?
Yeah, it's a tougher one. I mentioned it's a theoretical construct. So there are things like cognitive reserve questionnaires. It's just asking with all those things of lifestyle, are you adhering to those? And it's kind of estimated, not a great measure. So it's really not, you can't just go to your doctor and like, what's my cognitive reserve score? That doesn't really exist. So it's more of a construct. But if you're getting your brain health measured in different ways, cognition, brain imaging, blood testing, you look at what you're doing with your lifestyle. It's something that's insinuated. But there's no specific cognitive reserve test with the exception of a couple questionnaires that are still being researched.
Okay. I am not seeing any more questions now, but folks, if you want to keep typing in your questions, I will say thank you so much to Ryan for sharing your knowledge with us today.
Always a pleasure.
All attendees will receive an email with a speaker evaluation for today's webinar, and it includes a spot to indicate which continuing ed credit you'd like to receive. So please be sure to complete the survey. And even if you're not looking for a CEC, we'd love to get your feedback. And we'd like to say thank you again to our sponsor, Reaxing, creator of the only indoor training system that fully involves the sensory system and shifts the focus to the nervous system. So
very open skill, might I add.
Pardon?
Very open skill, might I add. Unpredictability in fitness.
Nice. So check them out online at reaxing.com. That's REAXING.com. And I'll also send out that link in my email afterwards, along with Ryan's link for his brain health trainer course. Let's see, nope, we're good. So I invite you to join us for our next webinar on Thursday, July 28th, entitled Introduction to Equipment Service and Maintenance with Daniel Schwartz of Life Fitness. Now, even though Daniel is with Life Fitness, this will be a general maintenance and service webinar, not specific to Life Fitness equipment. Daniel's background is as a personal trainer, so he's familiar with lots of types of equipment. We have many more webinars coming up, so please visit the MFA website at medicalfitness.org for a complete list of topics, dates, and times. Oh, and we do have one more question here, so we can't run away yet. Susan says, brain trainer certification includes lots of ideas for dual tasking.
It does, yes. Well, lots is relative. It includes, I think, enough to inspire your creative juices. It's not full-blown turnkey programming. Everyone always wants more programming. That's the biggest weakness of my professional endeavor. But yes, it includes plenty of ideas.
Awesome. Well, great. Well, thank you all again for joining us today. And thank you to Ryan for sharing your knowledge. Enjoy the rest of your day, everyone.